Welcome to the Functional Neurologic Disorders Society podcast. I'm your host, Erica Cotton, coming to you from Chicago, Illinois, with a special thanks to Michael Romeo, our production engineer, coming to us from Australia, and our content curator, Ingrid Hertzauer, from the UK. Today's guest is Dr. Matt Butler, a doctoral clinical fellow. He is a psychiatrist at King's College in London, also completing a PhD that is Wellcome Trust funded, focused on neuropsychiatric disorders and psychopharmacology. In today's episode with Dr. Butler, we will discuss his background and pathway into FND, psychedelics, clinical trials using psychedelics, his currently funded clinical trial using psychedelics in FND, and the various components of that. Many FND and psychedelics related topics such as gender and trauma, as well as hopes for the future of FND research with psychedelics. I sincerely enjoyed this conversation with Matt, and I hope you all do as well. So without further ado, here's my conversation with Dr. Matt Butler. Thank you so much for joining me today. It's been wonderful to read about your background and your work, and I'm super excited to have this conversation with you today. So why don't you start by just telling our listeners about your academic background, how you arrived at having FND in your work, and kind of the career path you're on, because everyone has such different trajectories and entry points into FND and the world of FND research.
Wonderful. Yeah, thank you so much for the invite, for having me, and for being interested in what I'm doing. It's much appreciated. Given the chance to sort of talk about myself, of course, I want to lap that up. So I kind of expected a question like this to come up of how did you end up in FND research? And I'm afraid I don't have a very good sort of specific answer to it. It's all very kind of things just happen to me a little bit. But so I'll start with where I am now. So I'm a researcher doing a PhD in psychedelics for FND. So that's going to be the main focus, and we'll come on to talk about that. I'm also a clinician, so I'm a psychiatrist in training, and I work in the neuropsychiatry department of a London mental health trust. So my journey into where I am now, I guess, probably started in medical school. So when I first joined medical school, I wanted to be a surgeon, and quickly
you and my husband
quickly renounced that aim of mine, and I actually really got interested in neurology initially whilst I was at medical school. And I think alongside that, I was reading a lot whilst I was at uni, sort of fancied myself as a bit sort of highfalutin, got into some philosophy. I remember reading Antonio Damasio's book, Descartes' Error, which talks about the neuroscience of kind of consciousness and also of experience and how the brain and the body relate. And I think that was really quite an important read for me. And also, a little bit of an interest in philosophy. I'm not a philosopher at all, but I remember reading about Immanuel Kant and his kind of Copernican revolution that back in the 18th century, where he talks about the idea that experience is partly constructed by the brain, and that we're not some passive receivers of the sensory information that we get from the world around us, that there's an active process, and also with that active process there is a kind of constraining of experience by the brain itself. And I think that retrospectively that was quite an intoxicating idea for me. And I think that as I sort of came towards the end of medical school, I kind of realized that maybe my personality suited psychiatry a little bit more than neurology. For reasons I won't go into too much, because I know
they don't get too much into the philosophy of it. They can be nerdy, but not so much the philosophy. Yeah. I can't help but ask, have you read Gödel, Escher, and Bach?
I haven't. No. But tell me about it.
It's a fun read. Doug, we'll get off on a tangent before we know it, but it's Douglas Hofstadter. It's just a really interesting read, connecting these individuals and thinking about existence, and very similar to what you're kind of discussing of how patterns happen, what things mean, what is consciousness, what is existence. It won a Pulitzer for whatever.
Okay.
It's a little dense, but it's delightful if you like that kind of thing.
Yeah, certainly in my sort of more nerdy phases, I certainly would. But yeah, absolutely, it sounds really interesting. I think generally I just have this also they had this interest in consciousness and whether would ever be able to understand it. And I think that, that lends itself actually to working as a psychiatrist and a neuropsychiatrist. And I think that as, I progressed, I've sort of become very interested in sort of the wider aspects of the brain. I think that's why neuropsychiatry is such a good fit for me. And, it's certainly where I see myself in the future.
Have you read I Am a Strange Loop?
I haven't. No, I sound very poorly read now.
Oh, it's so fun. Yeah, that's a really good one too. Sorry, I'll stop giving you. Clearly, I have a nerdy streak too about this. This topic.
I'm always open to book recommendations. Please don't feel you shouldn't give them to me. But there's such fascinating literature and kind of covering all this, and they're really quite fundamental questions, I suppose. So as a junior doctor, I'd seen patients with functional presentations, mostly during medical jobs. And actually, I have to say that at that time, I didn't quite necessarily realise how interesting these presentations would be. I do remember, though, that I was left with a feeling of that some of these patients were being very dismissed, and there were jokes behind their back about, for example, some patients who had functional seizures on the wards. And there was discourse within some people on the team that they were kind of putting it on, or at least putting it on to an extent. And I remember thinking at the time that this doesn't sound right. I don't know why someone would do that. But apart from having that feeling, I didn't really sort of explore things. And of course, I cared for the patients as I would do any other patient. But it was really when I came to work where I am now at King's that I sort of developed an interest in FND particularly. So I met Tim Nicholson, who is a bit of a big name in the FND field, and he's just a really lovely guy, and he's become my supervisor both clinically and academically. And actually, my interest in psychedelics and neuropsychiatry and FND kind of converged at the same time.
Oh, that's so interesting.
So I kind of came into FND actually kind of via psychedelics in a way, because I was reading. Cool. Yeah, so probably not the sort of usual path, but I was reading, again, academic literature about the old trials of psychedelics in different neuropsychiatric disorders. And one thing that was written in one of the papers was, there are signals in these old literature that that FND might be a good target for psychedelics, but we need someone to summarize the data essentially. So I thought, that person can be me. I know a little bit about FND. I know, it's definitely within neuropsychiatry, and that's when things all started. And then from there, I've had this sort of parallel interest in FND and psychedelics, and I've had clinical placements where I've, sort of helped manage and diagnose and treat FND. So kind of come from that angle as well. It's all been fascinating, and I'm, really glad that I sort of started on that path in the first place.
That's interesting. Did you have any idea that you were going to end up in psychedelic research when you
Absolutely.
started? You were on the surgeon path. You're
absolutely none whatsoever. Yeah, I think I would have, if I could speak to my 17-year-old self now, I think he would be quite shocked. I do remember again, another book that I read was David Nutt's Drugs Without the Hot Air, which is a book that he wrote a while ago, and talks about drugs and the sort of evidence for harms and benefits, and sort of thinking about it in medical sense. So David Nutt is a UK psychiatrist with an interest in sort of psychopharmacology and drugs. And I remember reading that and his description of psychedelics at the time, and how, he was saying they were actually quite safe when administered in a medical setting, and that they do have potential for treatment of things like depression. But again, it's something I just read, found really interesting, and kind of put to one side. And it's only kind of coming back into the environment where we are at King's now, where there is psychedelic research going on, that I sort of rekindled my interest.
Yeah. I mean, I think if you have an interest in consciousness, volition, agency, it naturally lends, and substance, right? Because substance alters that consciousness in a very specific way. All of those pieces converge, and you can't kind of help ignore that potential convergence in FND. And you kind of highlighted this with your discussion of, is this volitional or is it not? And that snickering, which I agree, I hate, and it just doesn't quite fit the presentation. But it does beg the question of, is there this hard and fast, it's involuntary or voluntary, or is it more of a spectrum of voluntary versus involuntary within the brain? And where do people with FND lie, and how can we move and change those systems to help alleviate the suffering that is happening, right?
Yeah, completely. Yeah, absolutely. I think at medical school, the first thing you learn is how the body works in order to then understand how it can go wrong. And I think that I think the understanding of how the brain works can also lead you to the same conclusions. Well, if these things are kind of the processes the brain does, then there's because they exist, there's a possibility they could go wrong, and that includes things like volition and agency and things like that. So it almost would be a strange world if those things couldn't go wrong or didn't go wrong, because of course they're a process that's so.
It's a body process, right? It's like
absolutely.
something can go wrong with it. Any body process, unfortunately.
Exactly, yeah. So it's a physical process, so it can go wrong.
Yeah, awesome. Well, that is a great segue actually into talking about how we even go about studying these sort of conditions, and the aspect of when you're using psychedelics to look at consciousness, to look at changes in a disorder. I mean, there are researchers who look at just the pure impacts of psychedelics, not disorder related, but it sounds like your pathway has taken you to, fortunately for us, FND to be included. So why don't you tell us a little bit about what are the basics of setting up research trials in psychedelics with specific disorders?
Yeah, great question. Thank you. So I've been really fortunate to be able to work on clinical trials of various different neuropsychiatric indications. And again, that feels like something that I just happened to be in the right place at the right time. Of course, I brought with it an interest and a curiosity, but there's an amazing clinical trials unit in psychedelics here led by James Rucker, who's a psychiatrist, and he's another fantastic supervisor to me. And he's been instrumental really in being really at the forefront of setting up some of these trials. Back years ago, it was almost inconceivable this could be happening, but now we're sort of seeing psychedelic trials wherever we go. But I think there's good reason for that, and that's because they're potentially they could be beneficial for people. So the main trials that I've worked on is with people with depression, with treatment-resistant depression, but we've also had interesting trials with people with PTSD. And also we've worked on a small trial with a headache disorder called Sunha, which is a trigeminal autonomic cephalgia. So it's a very, very painful headache condition that is quite rare, but there are people who don't respond to treatment. So that was a really exciting indication to give the psychedelics in. We haven't published the results of that, unfortunately, so I can't really share those just yet. But so the question was about how setting up trials, and I think that they're for whatever indication, there's lots of complexities that go into arranging and organising trials of psychedelics. Not least, I mean, it's very variable across country, but in the UK at the moment, psychedelics are illegal, and that includes for research and medical use.
Oh, really? Including research and medical?
Yeah,
okay.
Exactly. Yeah. So they're in the UK, they're under what's called a Schedule 1. In the kind of Misuse of Drugs Act or something. So that means that the Home Office have said that there is no medical use or even potential for these medications, which is a bit strange because they are allowing research into psychedelics, but I don't think there is the political appetite at the moment in the UK for any sort of change in terms of relaxing legal restrictions on research, which is a bit of a shame because I think, if anything, we proved that there is at least possible potential in these substances for, at least in terms of research. I'm not, I don't really want to comment about kind of recreational use.
We're not talking about recreational. For specific disorders in a controlled environment.
Yeah.
Yes, by a professional with a good quality grade product.
Exactly. Yeah, exactly. So, in very controlled settings with, experienced people, I think, we're at least at the stage now where we can say, look, these are safe. And that there is potential for effectiveness or efficacy. I don't think we're anywhere near the stage yet where we can say, look, there should be used in clinical practice. But yeah. So anyway, I'll get off my soapbox. But that's one of the sort of legal hurdles that we have.
That's important. Just to clarify for our listeners and myself, guess if I'm ignorant of something, I always clarify the listeners. But in terms of these trials, or specific to the UK as well, what sort of substances are we discussing? Psilocybin, LSD, ketamine. I know ketamine in the US is now ketamine treatment clinics are more prevalent even in academic medical centers. Is ketamine on the list in the UK of no?
Yeah, good questions. Yeah, should have clarified. So psilocybin is probably the big one in the UK, and that is because partly because most of the research has been on it, but also because of the duration of action. It tends to be between 4 and 6 hours. So from the time of ingestion, usually it's given as a tablet, to kind of feeling back to your normal self, it takes about 6 hours or so. So that means it lends itself really nicely to a kind of day case. You know, you can come in the morning, you can have a dose, and then by 5 o'clock, you're on your way home with someone. We have also done research with other compounds, and you know that of course there's other research going on across the world and as well as in the UK. We've looked into a compound called 5-MeO-DMT, which is a psychedelic, but it's very short acting, so it acts perhaps for about half an hour or so, and that's administered. It can be inhaled or it can be administered intranasally, which is what we did. And that's there are groups that are looking at that for potentially in depression. And that's with those sorts of substances, there's much less emphasis on the psychotherapeutic component because they're very short acting. Generally, people find with these short acting ones, it's not quite as, it doesn't lend itself quite so much to kind of narrative formation or symbolizing of the experience, which psilocybin does. You know, psilocybin trips can sometimes be described a bit like a journey. And that's why, you know, it might be helpful to have a sort of guide, or there always is a guide there with the patients that we do, but so who sits with them during the experience and then also helps them to integrate the experience afterwards. We can talk more about that, obviously, in a moment. But ketamine is used in the UK. It is under a different schedule than sort of classic psychedelics. And that's because it's licensed for use as an anaesthetic in the UK. And there are a few, not many, but there are a few ketamine clinics as well in the UK. So ketamine-assisted therapy that are private clinics. Of course, in the UK, there's a big difference between public healthcare and private healthcare. So, and also there are ketamine clinics and specialist centres, like, for example, where I work, that are using intravenous ketamine sort of off licence, but, you know, with a little bit of evidence backing for treatment-resistant depression as well. I think with ketamine, there are certainly a lot of similarities to kind of classic psychedelics like psilocybin, but I think that there are important differences in the way that it works as well. And I sort of feel slightly uncomfortable with it being labelled as a psychedelic, although I completely understand why people do, because there are lots of similarities. But I think the mechanism of action and the kind of subjective experience is different enough that it perhaps warrants its own kind of, at least its own sort of research.
Yeah, it's a separate category almost. It is a separate category. Exactly. Yeah, excellent. Yeah. One other, before we get into your research trials, there's one article that you've written that I'd love to discuss, expectancy and placebo-controlled trials of psychedelics. If so what? My favorite title ever of that, but you raise really important questions in that article about when you're considering testing these drugs, what are the reasonable confounds, and kind of thinking about the problems of doing this research against traditional research standards with these specific compounds that are kind of unique, that you suggest we need to think pretty pragmatically about and kind of be reasonable. But I love the title, and I'd love to hear just more of your thoughts about, as you were designing these trials, you know, those pieces that you're keeping in mind and how that contrasts with like a typical randomized control trial.
Of course. Yeah, so I have to acknowledge that the title is slightly provocative, but, you know, it's what we landed on. It seems to have got a bit of traction. So this is the paper where we discuss the concept of expectancy, which I'm sure all the listeners know is the sort of phenomenon that people bring to any kind of, I suppose, any experience, but particularly with it in terms of a medical intervention or a medical setting, where their internalized beliefs, often subconscious, about how effective the treatment will be, or what form the treatment may take, or what the side effects might be, how those expectations affect the outcome or improvement of a disorder, or how they affect the clinical course of something. And I think expectancy, you know, it's very related to placebo effects. It's probably sort of enmeshed within what we call placebo effects. And as I say, it's a broad phenomenon which affects essentially anything. But I think in psychedelics, it's really heightened. And
there's some expectancy there. There is
certainly some expectancy. You know, these are held up as, they're very sexy, you know, in vogue drugs that are being portrayed in some quarters as almost miracle cures. And I'll talk about that in a moment. So I think when we talk about expectancy, it has to involve the person knowing a little bit about what they're taking, because, well, it doesn't have to, I suppose, but in many cases it does. So one way you can try and get around that, in of course, placebo-controlled trials is to use the placebo so that the person is blinded to what they're getting. So they don't know whether or not they're getting the active drug or they're getting the placebo. The expectancy will, of course, still be a phenomenon then, but it hopefully will average out over the two arms of the trial if they don't know what they've got, if they're not unblinded. We have the inherent problem with psychedelics that most people, although not all, but most people do know when they're given a dose of psychedelic in a placebo-controlled trial. It's a little more obvious. I mean, there are some interesting things about people, inducing kind of psychedelic experience on placebo. Sometimes people who have the active dose they're perhaps very resistant to the experience and they feel like they got the placebo, but these are the exceptions. The doses that we typically use in psychedelic trials is around 25 milligrams, which, given that to sort of average person, that have a definite recognizable psychedelic experience. So through that process of getting the active drug, they become unblinded to what they've had.
Right, of course.
And so this can sort of almost ramp up the expectancy effects in people who've been assigned to the active arm. So they've come be hoping that they'll get the drug. Maybe they're allocated 50-50 chance of getting it, or the placebo. They get the drug. Yes, I've got this miracle cure. Fantastic. I'm going to do well. And so you get this inflated sort of drug effect or drug times expectancy effect. Whereas in the placebo arm, that after an hour they think, oh, I'm not really feeling anything. I was hoping to get this miracle cure, but actually I've not got anything. I've just got a sugar pill. So there's this disappointment effect, and sort of all the expectancy effects that were there previously now get washed away. So you have this reduced sort of placebo or expectancy effect. So that amplifies the difference between the active arm and the placebo arm. So I've hopefully explained that, understandable enough to say that, this means that the trials that we're doing of psychedelics will inflate how effective they are in comparison to perhaps if these expectancy effects weren't there. And
which is somewhat, it sounds like it's just somewhat inherent in the drug that you're studying. In that it has this quick acting, high impact experience potential versus if it were a drug that lasts over a long, interacts at a slower pace, at a slower time with more gradual impact over time and not quite this high yield, high risk, high reward, high yield kind of outcomes. So it's just kind of inherent in exactly what you were describing of what the ideal kind of psychedelic drug to study is.
Yes. Yeah, I think so. And I think this is what we try and sort of get across in a sort of scientifically minded way in that paper is that these are, we have to acknowledge these problems in the sense that, we're going to be looking at data which is going to be enormously supportive of, of psychedelics, but that doesn't mean that probably partly because of the inflated expectancy effect. However, that doesn't necessarily mean that we should be ignoring these data. They are, as you say, inherent in the process of dosing someone with a psychedelic in a trial, and I don't think that these ramped up expectancy effects should remove completely any optimism in them being effective. And
they don't overshadow that optimism effect, or expectancy effect does not overshadow or outcast the actual benefit of the substance.
Yes, exactly. I think they certainly temper it, and I do really want to advocate for caution. And I don't think we need to. We should not be rushing. What we're doing in terms of licensing these drugs. But one reason we wrote this paper was in response to various different kind of pieces that have been written and spoken about, which almost seems to suggest that psychedelic trials had a kind of categorical difference to other drug trials in the sense of these expectancy phenomena, these unblinding phenomena were unlike anything we've seen before. And because the RCT, the randomized controlled trial, is the gold standard, we can't fit psychedelics into those. Therefore, there's kind of implying that we shouldn't really be researching them because we're not set up to do so. But I think that's what we wanted to challenge, to say, look, actually, we need caution, certainly, but it might just be something we have to accept. If so what? As long as there's not evidence of significant harm, and as long as we're tempering our expectations, then do we just have to accept it?
It reminds me actually a lot of for pre-DBS evals, they do a Cinemat study where it's the same thing. Cinemat takes an hour to kick in. They come in off. They give them a dose of Cinemat that definitely they should respond to. There's an expectancy. They know that they're going to respond to Cinemat ideally. And if they've been on it before, you reassess them and the benefit of, it's just imagining for the RCTs of something like a dopamine agonist. It's probably very similar sort of expectancy bias impact.
Yep. And I think these concepts are exaggerated with psychedelics, but as you perfectly alluded to there, they're not. I don't think they're not unique.
Yeah. Definitely, probably more related to the drug of study, the quick action, and the extent of benefit that might be experienced. Yeah. Awesome. Okay. So now, super excited. Tell us about your upcoming trials and how you're structuring those, what you're hoping to achieve. Also, any obstacles that you encounter, just I feel like we don't talk about the obstacles in grad school. Yeah. We don't talk about the obstacles out in shiny public, but I like for myself and listeners to hear like, oh yeah, this is in a real world setting where things happen and there are hurdles in place. So if you'd like to share any of those, or if it went perfectly for you and you mastered it beautifully, then please feel free to share your secrets with that as well.
Yeah, no, I'll give you the warts and all story. I'm in a nutshell really, really fortunate and really excited about a trial. So it's not technically a clinical trial. It's a sort of open label study of people with FND who we're planning to administer 25 milligrams of psilocybin, which is the kind of sort of standard dose that we use in these research trials, alongside kind of psychological support. So this has been a sort of few years in the pipeline. I think, I mentioned sort of being supervised by Tim Nicholson and reading these these reviews of the old literature of psychedelics and getting excited at that point. And I think that, it was through Tim's support that he kind of encouraged me to think about whether or not, we're actually really quite well placed here to think about a trial for FND. And the people around me, Professor Mark Edwards as well, who's done a lot of work on predictive processing and FND, also works in our group, and he's been very supportive, thinking about the kind of theoretical aspects to justify why FND might be actually a great disorder to trial these medications in. And so I started off doing some kind of groundwork. We sent out a survey, and we were really fortunate to have enormous engagement from FND patients via charities. We got over 1,000 responses to that survey. This was about 5 years ago. And we asked them loads of questions, so it was a really long survey. So I'm enormously grateful for everyone who did that, if there's anyone listening. But one of the questions that we asked was about whether or not they'd be willing to undergo sort of psychedelic treatment for their FND. And at that point, we found that roughly half or so was sort of on the yes, I would try it too, yes, I'd definitely try it spectrum. So there were these, there was sort of patient interest. And then we, together with Tim and a few others, Richard Cannan in Australia, we amalgamated the old research, the old case reports of people who'd been given psychedelics in a sort of pre-prohibition era. So this was the first phase of psychedelic research in the 40s, but mainly 50s and 60s, up until about 1970, when there were much more lax drug laws generally. And that meant that psychiatrists and researchers were able to look at psychedelics for mental health disorders. So this is back in the age, it sounds so strange, and this is only probably, 60 or 70 years ago, where Sandoz, the drug company, were literally shipping out free LSD to psychiatrists to say, do with that what you will. This seems to have pretty profound, exactly. Seems to have pretty profound effects. You guys go and try this on your patients, even maybe try it on yourself and see what you can come up with. But anyway, so there were these, it was a slightly sort of cowboy time by the sounds of it, but there were some interesting case reports anyway that came up that suggested that people who have FND or sort of FND-like syndromes, you can never be sure with data that's that old, but they responded quite well to the psychedelics. So, and plus we sort of looked into the neuroimaging data, found that maybe some of the regions that are implicated in FND, although, the literature is not sort of entirely robust at the moment, but it's improving. Not fully formed, but there are little sort of nuggets of suggestion that some of the regions that are most impacted by psychedelics could be, impacted by psychedelics. Regions that are implicated in FND. Yeah. And so we thought, well, let's go for it. Let's put some funding in for a PhD for myself. It was kind of the right stage of my career to do that. And so I presented to the panel at King's and funded by Wellcome. Said, look, I want to try giving people with FND some psilocybin. I have experience doing that with plenty of patients now with other disorders, and we want to scan their brains to look to see whether or not anything that we've seen in the literature is replicated in FND. And I'm enormously fortunate that they said, yeah, go on, you can do that. So which is amazing. And so in the past year or so during the PhD, I've been basically trying to set up the trial. which has been challenging. Everything takes forever in research. Everything seems like it needs to be duplicated about 4 times before it can be approved.
I'm always gratified to hear other people's experience of this as well. It's like, oh, it's not just me. It makes me feel so much less alone in my frustration.
Yeah. I think sometimes the difficulty is that some of it seems reasonable, but then you're like, actually, is this reasonable that I need to do this? I need to duplicate this information, I need to go through this approval. And there's different aspects of the approval process. They're looking for different, proof of different kind of aspects of the trial that they want to see. And so it's been a long process, but expected to be long. I'm fortunate that I'm sort of around an environment where we've done other psychedelic trials, and there's actually now just very recently opened up a kind of bespoke psychedelic center here at King's as well, where we can dose people with psychedelics sort of away from kind of hospital environment, which is great. But my trial, I am now just paying the Home Office, who have control of the Schedule 1 licenses in the UK here. And once that payment's gone, then the trial should be green lighted. So I'm really looking forward to that. Yeah, absolutely. So recruitment's going to start very soon. We are looking, I don't know when this podcast will go out, but we are looking for recruitment from different avenues. Essentially, anyone who's got at least moderately severe FND and has tried at least one treatment. So, for example, psychological therapy or physical therapy or anything else that's been recommended for their FND, and it's not worked. So they've had the symptoms for a while, and at least one treatment's been tried. We are looking for FND subtypes sort of quite broadly, but with a focus on motor and seizure symptoms. So probably not someone with just isolated functional cognitive disorder, for example. I can go into that, but sort of reasons, particularly in terms of engagement with psychological support and things like that, which want to make sure that it's very safe. And so we've been a bit restrictive for that. And
that makes sense. We could have a whole separate conversation given my interest in FCD about that.
Yes,
I'm going to put a pin in that and resist the urge. You and I can get together and have a cup of coffee at another time.
Definitely, there are exciting things to come after this, but I think, we have to lay the groundwork.
Yeah, it makes sense, actually, because if you want them to be psychologically supported and they're cognitively not able to engage with psychotherapy support in that moment, you're kind of removing a safety.
Yes. Yeah. I mean, that's not to say that in the future is not something we tried, but I just think, we're playing it sort of safe for the moment.
Yeah.
But the psychological support will be pretty much exactly the same as in other psychedelic trials. So it's not kind of active psychological therapy per se. It's more getting to know the therapist, who is a sort of experienced psychedelic therapist. They'll hear about the patients and they'll be present for all the dosing, and then they'll help with the kind of integration phase afterwards. But it's mainly to get to know someone who they feel safe with during the dosing, and to think about things that might, quote unquote, come up during the experience. Mm-hmm. Some of that may be related to difficult experiences in the past. Sometimes it's just, difficult things that are being processed at the moment. Sometimes the experience is wholly positive. So very variable. So that's why we like to have someone there to support things. And as I say, we'll be doing scans of the brain, fMRI scans before the dosing and after the dosing, and seeing what the changes are. And of course, we're interested also in whether people get better or not.
Time frame of the after the dosing? How much longer after the dose?
Do they have the scan?
Mm-hmm.
1 week.
1 week. Okay, so not immediate, but
no. So there's no scanning, because there have been trials where people have been scanned during the experience, but no, it's the day before and then 1 week after the dosing. So we're looking at to see whether there's, because there is thought to be a sort of afterglow period for a few days after a psychedelic, and it may be those kind of ongoing processes. So we want to try and capture it sort of more after that's finished. Hence why it's
after it's finished, but enough so that you could still probably capture any potential impact that might have happened. Yeah,
exactly. Yeah.
And to clarify the support, it sounds like the intent of the support is to support the psychedelic experience in that form of the support or psychotherapeutic, not really intervention, not a primary FND intervention where you're in any way inlaying a structure of FND treatment onto their psychedelic experience. It's more just have a free-form psychedelic experience without expectations towards FND with a guide for the psychedelic experience, not FND focused or any embedded FND treatment within that experience. Does that make sense? Am I capturing that right?
I couldn't have explained it better. Yeah, absolutely. Yeah.
Awesome. Great. What outcomes are you hoping for? If you don't want to say, that's fine, because it's just
That's okay.
Don't want to jinx it, but also
well, I mean, so this, as I say, this is technically for various different reasons. It's not a clinical trial per se. So this study won't be powered to look at to sort of make conclusions on any clinical efficacy, and particularly because it's not controlled. So there's no control. Mm-hmm. Everyone who gets in the trial will have the dose. They'll have a single dose. But that's, of course, we're extremely interested in the people's response to the psychedelic. And at any trial at this stage, we're mainly interested in whether or not it's feasible to give this medication in this patient group and whether or not it's safe to do so.
Right.
In this trial, particularly, I'm also looking at sort of functional MRI changes, so kind of the way that the brain is talking to itself and pre and post. So that will be the kind of primary outcome. But we're also looking at sort of more mechanistic measures, so measures of interoception, measures of dissociation, measures of agency. And the reason why we're sort of doing this is quite a sort of scattergun approach to see, to just probe the idea of, well, what is going on, if there is anything going on, what's happening, because we don't really know with psychedelics what happens. And even in something like depression, where there's much more evidence and experience, we don't quite know why it works. And that's certainly the case for FND. So I think, I'm taking quite a sort of broad, almost hypothesis neutral, I suppose, approach to this research, to saying, let's just kind of see what happens. Mm-hmm. I have some ideas about the sort of brain regions that might be effective. So in the default mode network, that's been the most reliably shown to be affected by psychedelics and may be implicated in FND. So it'll be really interesting to know whether or not that's a region that's affected or changed by the psychedelic or not. But otherwise, we just kind of sort of see what happens, with fingers crossed that people don't do poorly, which I really don't expect they will, but also a little bit of a fingers and toes crossed for whether or not they're going to clinically improve as well.
Yeah. So I'm hearing outcomes regarding the aspects of conscious experience, right? So alexithymia, interoception, agency, et cetera. The harder, maybe I'm biased, harder outcomes of symptom improvement, which I know might not even be an aim of yours, but throughout all of FND, it's hard to objectively measure, given the heterogeneity of the symptoms and presentation, objectively measuring symptom improvement. I mean, we get the patient reports of, clinical global impression of change. Are you better or are you worse? Which is kind of, that's useful to have in this population. But in terms of objective improvement in functional seizure frequency or functional movement symptoms, which measuring outcomes in functional movements is its own whole space of issue and complexity and difficulty. My husband's a researcher in PM&R and trying to measure motor outcomes for that population. But you guys don't have good motor outcomes. I'm like, wait a minute. So how are we supposed to have good motor outcomes for FND? Like primary rehab doesn't have good motor outcomes. So how much are you dipping your toes in that very, very muddled and deep pool?
Yeah, I mean, you've of course acknowledged some sort of real challenges. So we are just going to be using the clinical global impression as the main clinical outcome.
Brilliant.
Because of the complexities you mentioned, also because, I don't want to be too grandiose. This isn't a clinical trial. So we think to using clinical outcomes like that, the funders or the approvers might have said, why are you doing that? One thing I'm really interested, though, is in the participants' experience, both of the psychedelic trip itself, but also the, whether or not there's been any improvement. And again, because I'm essentially clueless mechanistically about what will happen and if there is any improvement, one of the ways I want to try and get at that is through a kind of phenomenological approach. So we'll basically just be interviewing the participants after the experience. Again, quite sort of broad, no specific agenda with those, but just be interested to see what the participants, obviously what they feel about their experience, but then if there has been any improvement or any change in their symptoms, if, be really fascinated to sort of probe what their kind of experience of that was or why they think that might have happened or what in particular has changed. Again, quite hypothesis neutral, but I think hopefully that will capture some of the if there is any improvements as well, that'll be captured by these interviews.
Brilliant. Yeah, that sounds great. It sounds like the right trial design for the state of the current literature, as well as specifically for FND in its sort of infancy and looking at this potential benefit. Good segue into one of the other pieces I wanted to discuss, which would be is there literature on using psychedelics or psilocybin specifically when it comes to gender, diversity, trauma? Are there certain people who shouldn't be candidates for this intervention. Are there any differences to be mindful of, and how might that also relate to prevalence rates and FND as well?
Right. Yeah, really good question. I think I'll sort of take that question into two parts. Firstly, the kind of gender and diversity thing, because I think it's a real problem with psychedelic research. It's a problem with research in general, to be honest, but it's a particularly acute problem in psychedelic research. Thinking explicitly about recruitment, generally so far in psychedelic trials, I'm not talking about FND here, but it's been mostly kind of white educated men who get picked for the trials. And
that's not exactly the FND demographic.
Exactly. So of course, we're looking to change things, and we are doing so here at King's already. So in our trials, for example, with our depression, we have sort of targets for diversity. So that's a lot of protected characteristics, not just sort of gender and ethnicity and things, but various different protected characteristics that we sort of average between the rates in London and the UK as a whole, and kind of take the average of that, and then because it's countrywide recruitment, and then we try to sort of make sure that we're sort of enrolling a very representative participant population, essentially, in these trials. And so, of course, I'll be looking to emulate that in my FND trial. As you, of course, correctly point out, the psychedelic research kind of typical demographic is not representative of FND. So I think it's really important that we kind of proactively acknowledge that and make practical steps to do things about that during these trials. So I hope to essentially sort of springboard off the methods used in the other trials for my own trial to ensure that we have a kind of representative population. And then I think trauma is a really, really interesting one. It's obviously quite a thorny issue in generally in FND, and I think I generally am supportive with the research that suggests that for many people with at least a sizable proportion of people with FND, trauma is implicated, or at least seems to be a risk factor. But for some people, it doesn't seem to be. And
a higher percentage, but certainly not everyone.
Yes, exactly. Yeah. So, we do, of course, see trauma. Trauma is not a specific risk factor for FND. Of course, it's, I think it's much more complicated than that. And we see trauma in other neuropsychiatric disorders. We see a history of trauma in lots of people with depression, particularly treatment-resistant depression. I think, on the one hand, psychedelics seem to lend themselves to the processing of trauma. And I think that we've seen some really interesting outcomes in the PTSD work that we've done. Again, it's not published, so I can't share anything specific, but it's interesting findings. And
it's okay, we'll just have you back in a year.
Yeah, please, yeah. And again, in the depression work that we've done, there are people who have experienced kind of adverse events or traumatic events, and the psychedelic seems in some instances to be really helpful for processing. And I think particularly when it comes to things like self-compassion, that's a real thing that I think is important in some cases. Not that I'm saying that's explicitly relevant in FND, but it seems to be something that perhaps even just goes along with the kind of processing of the trauma, and people are able to sort of see things a bit differently. However, on the flip side, of course, trauma leaves its mark on people sometimes, and there can be challenges that, particularly when there's repeated childhood traumas, that can be sort of dragged into adulthood, and it can be very difficult for people to feel safe in environments when they've had, sort of persistent adverse events or abuses. And psychedelics can be, they're a very powerful tool in a way, but they can also be very, very destabilizing. And I think that in itself may represent some of how they can be effective, because it's almost like they're kind of shaking the brain up a little bit. But, people in these trials don't always have a positive experience, and they can be sort of processing which feels very negative at the time. Even sometimes people report emotions like dread during the experience. It can leave people feeling a bit vulnerable afterwards. And I think that there's a little bit of worry that some people with if they have a history of trauma, a lot of terrible things have happened to them, that giving them a drug like a psychedelic, which is quite destabilizing, and this is particularly when there's perhaps a social network around them that we're not sure would be, completely supportive of the participant, or just that there isn't access to that social network.
Right. And especially if the environment's unstable, or if they're already in an unstable state psychiatrically, it's just vulnerability on top of vulnerability.
Completely. Yeah. So you put it better than me. Yeah. So all these vulnerabilities we're thinking about when we're thinking about, is this trial the right fit for this person and the right time? So unfortunately, I think sometimes trauma can become a really complicating factor with psychedelics. And, that's not to say that I think this will always be the case. Perhaps, or probably actually, as we get more experience in using psychedelics, we might have a better understanding about these kind of destabilizing aspects and how better to support them. So it's it's a very sort of difficult line to tread, sort of trauma and psychedelics. It's something I'm really interested in. I think that, on the one hand, it's really promising in some ways, but on the other hand, we just have to be really careful and acknowledge that there is the potential for harm, particularly when as you say, there are these kind of existing vulnerabilities.
Yeah. I mean, it actually reminds me a lot of just the general psychotherapy or behavioral health planning approach for people with a history of trauma is, how front and center does that trauma intervention need to be? How stable is that person when it comes to the trauma, or for other reasons? And is this the right time for this specific intervention based on all these other factors, which really isn't different whether the intervention is a 14-week manualized CBT trial or a day at the psychedelic spa, which they have this experience, right? But I think the criteria would likely be similar, where we don't want to take someone who's acutely still traumatized or unstable because of the trauma, or psychosocially unstable and unsafe, and say, oh, we're going to give you a manualized 14-week, CBT intervention, and this is going to be what's going to work for you. We wouldn't do that. So I imagine it's probably very similar criteria or similar approach, which, is something just to be thoughtful of, and not at all a contraindication. It's just the right person at the right time making that decision. Yeah.
Completely. Yeah.
Along that lines, as you were speaking, I had a thought which pulls in also the use of other substances for the treatment of trauma. So I think, one of the mechanisms, I love your humility around the mechanisms as well. You don't know why these work. It's great. It's just that admittance is perfect. But, kind of this shaking up the brain, right? You're really, it's not delicate. You are robustly changing something in that moment at that time. So just kind of that shake up in the default mode possibly, but also I wondered about, from a trauma perspective, if, the same way that kind of like EMDR sort of works, which is if you switch the attention or you add a different epoch or a different piece as the trauma is being discussed, it kind of creates this separation or this barrier, this space from the initial encoded trauma experience with all its visceral components, and kind of adds space, time, basically the same way psychotherapy works, which is you add these layers around it and create something different and buffer that experience or digest that experience and put places and safety and buffers and holds around it so that it's not, this free form, overwhelming emotional experience. And I wonder if you would hypothesize or share a potential view that also just that psychedelic experience is probably like a pretty significant epoch in time that might create incidentally just like that space or separation, or if they experienced any element of their trauma in that experience where it's just so radically different that it then creates some space for it. What do you think about that? Or am I way off base?
No, I think you're really, really sort of hitting on something which I think is a theme that's developed through my work with patients in this in the psychedelic trials, both with depression and PTSD in particular. And I think sometimes with some of the participants, these are such debilitating disorders, and it sort of feels like there's such an entwinement of the condition with the person, and it feels like no matter how hard they try, they just cannot escape from that. And so sometimes I talk about with participants, I try not to be too symbolic during because my role is very much as a medic rather than the therapist, but we think about this sort of distance that the psychedelics can sort of help create between the person and their symptoms and their disorder or their condition. And that sort of gentle lift off from what they're experiencing, or perhaps from their sort of the thought patterns that maybe were a bit circular, and just allows
the level of fusion that can happen.
Yeah, exactly. And that space gets created, and I guess the hard work is equally in sort of making use of that space after the experience, not just during it. But if this allows this sort of maybe alternative perspective, or this just sort of temporary break, if it is temporary, we don't know yet. We haven't done the longitudinal trials, but that kind of space is where the person then needs to sort of work and say, well, I have this gap now. I can see things could be different, and there is this space for me to work in, and how can I continue to use that or to acknowledge that, for example, just by maybe changing behaviors or changing thought, trying to actively change thought processes. But I think that gap needs to be created initially by something, of course, as you say. Psychotherapy is probably the perfect example, but potentially by psychedelics as well.
Yeah. And Stephen Hayes, forgive me, but acceptance and commitment therapy, right, is all about fusion and diffusion. And if someone's really fused with an aspect of their experience, or even like an involuntary process, like a motor symptom, and then something that robustly creates immediate diffusion from that, or radically changes that connection for that moment, might have a significant therapeutic effect by creating that flexibility that wasn't there before. Even if just temporarily showing that it's possible to have that flexibility, then you've laid that groundwork, and then it can continue to potentially be expanded on.
Yeah, absolutely. Yeah, completely agree. I think, I said that psychedelic therapy is sort of not an active intervention. That's true. It's, it's very sort of dynamic, not dynamic but it's dynamic in the sense that it's guided by the person. But I suppose the principle that it has most similarity and that some of it is developed from is ACT therapy. So I think there are real sort of overlaps there with how it's sort of conceived.
Yeah. On that note, I'm wondering, as we're talking about, fairly robust intervention, and like anything, there's licensing, there's training, there's, requirements that are beneficial. We're not talking about like legalizing psychedelics in the general population, specifically within a clinical context. What are your views about the legal hurdles or the licensing of providers who might consider using these interventions or doing research in this intervention? What sort of licensing credentials are needed for this?
Yeah. So it's really thorny issue. As you may have heard my irritation in my tone before when I was talking about these sort of legal hurdles, and that has practical effects. Although the Schedule 1 license for my trial is not very much itself, I have to use providers that all have these Schedule 1 licenses for themselves, and some of these are just feeding the basic processes of moving the drug from the place of manufacturer in the UK to a pharmacy in the UK where the research happens. And these companies charge a lot of money to do that. And if there wasn't a requirement for the Schedule 1 license, then that wouldn't be there. So the research is stymied by these sort of legal hoops that you have to jump. Yep.
Is the in the US, we have a problem, forgive me, with pharmacy costs or cost of drugs and drug markup costs. That's different than other countries. Bless our healthcare system here with its pros and cons. But is there a similar cost markup when it comes to psychedelics, or is it just so many hurdles related to access that's the barrier?
In my position, I suppose we as a sort of research group, the psychedelic trials group here, and myself, we're in a really fortunate position that we have really good links with private companies who develop and manufacture the psychedelic drugs, and they're really excited by psychedelics, and there's a lot of investment from various sort of fields or philanthropists, that sort of thing. So they do quite well financially, and so they're keen to support research in the UK, at least in my experience. So they, generally provide the drug at no or low cost to research institutes, and we have agreements in terms of what data we share with and things like that. And the pharmacy costs here for myself are pretty good, actually. I work with the pharmacy at the Maudsley Hospital, which is the kind of main psychiatric hospital, and they have sort of oversight of all these different scheduled drugs, and they've been enormously supportive. So those aspects actually here, in my experience, have been the much better ones, and some of the other parts of it, which have been expensive or time consuming, that sort of thing. And I think we're thinking about. So I think for me that's clear. We need to make research a bit easier. We need to make research cheaper in terms of thinking about these as potential medicines, because we need to do a lot more research for if we're ever going to think about whether or not we can license these drugs for clinical use. I think we're talking here about repeating studies in different disorders to make sure the results are replicated in different surroundings. I think we need more real-world samples, so perhaps aligned with kind of clinical programs, but still research. But because I think one problem is that it takes a certain type of person to be motivated to join a research study that's experimental, that sort of thing. But I think things are changing and psychedelics are becoming more normalized. So I think hopefully we'll start increasingly get sort of more real world samples in our studies. And I think that there are lots of different questions about mechanism, as I say, but I think one of the key things that we need to know about is longitudinal evidence for change. Are these benefits for psychedelics, if they are there, are they sustained for a long period of time, or maybe an X% of people they are? Are there some people who need repeated dosing in order to sort of maintain their wellness, or however you want to put it? And if so, over what period of time do we need to dose, repeat dose? Is there any evidence of long-term harms? I'd be enormously surprised there was, to be honest. I'm of the opinion that if given under medical circumstances, these drugs are enormously safe, both physical and psychological. But the fact that I think that doesn't mean that there shouldn't be due process in terms of monitoring. And of course, with any medication, that needs to happen.
It needs to be proven beyond.
Yes, exactly. Yes, completely. For people to trust in these as medications, of course, there needs to be the due process. And I think we just need more time. I think, despite the fact that, I've seen this as a completely different conversation to any on sort of legalization for recreational use. I think politics does come into it. I think, in the UK, like I say, I've alluded to at the beginning of the recording, that there's very little appetite politically for change at the moment. And that's partly because of the political system we have in the UK, with two political parties who generally one of them is looking to get in power, the other one's looking to hold on to power, and neither of them see relaxing drug laws as a good look at the moment, for better or for worse. Even though I would suggest that a lot of people in the UK now would be supportive of sort of my particular viewpoint, I think that it seems a little bit of a sort of political no-go at the moment.
Even for medical purposes, right? Because there's a difference between, relaxing drug laws for social or, societal use, let alone which is different than for medical purposes.
It is. I think, absolutely, there's a categorical difference. But I think that still I think their worry is that it would be conceived as maybe a slippery slope, or I don't know.
If just medical purposes, then society, and then you're.
Yeah. But there doesn't seem to be, there are the occasional debates in the House of Commons in the UK about whether or not we should legalise psilocybin. There are definitely MPs who are really supportive of it, and they'll present their cases really well. But there seems to be limited interest, really, particularly from the sort of main people in the political party. So we're due for an election this year. I don't know whether things will change after that. Who knows? But I think something will have to shift politically. Maybe it will. I think the weight of evidence eventually will get to the point. And also, we've seen in Australia that psychedelics are now, prescribable by expert psychiatrists for certain conditions. So that's a little bit surprising how quickly that's happened. But at least we can use that as a kind of case study to learn from them to see what happens. I think obviously things are changing in differential ways in the US as well. So we might learn from these sort of experiences. And
cannabis is legal in Illinois.
Yes, exactly. And
that's a big change for clinical practice.
Yeah, I mean, in the UK we can now prescribe cannabis. I mean, no one does, but you can do it. So that's been a bit of a change, but actually probably has affected practice in not that big a way that maybe surprised people. But yeah.
Yeah. Substances have an uncanny way of, I think, different than other medical interventions of pulling in societal issues, societal values, governance, and sort of those broader societal pictures, which, I would hope in a medical context, it's sort of a little free from more of those biases. It's intended for medical purposes and healing. Cannabis for epilepsy, right? It's much less frowned upon or provocative than just recreational cannabis use, right?
Yeah.
I hope that.
But I still think even so, I still think there's been such societal stigma towards the drugs, mostly from recreational use. But I think that the substances still drag with them this kind of slight aversion from people, and because they've always sort of been taught that they're nasty things that shouldn't be used. And even if there is evidence, I still suspect there's a little bit of lingering stigma, which may be changing. And I may be wrong about that. I don't know.
Yeah, and I imagine just a bit of a polarization as well of like
Yes.
who's open to them, who's not,
Hmm. Hmm. Hmm.
who's and how that changes responsivity or
Yes,
effectiveness for that particular individual. Yeah.
completely. Yeah.
I'd like to wrap up by asking if what are your next steps? Sort of if you complete your trial, where do you want to see this going? What do you think would be a reasonable next step? What are your hopes and dreams for the rest of FND or psilocybin and your clinical trials and where you see that going, what the next steps are?
Yeah. So I guess there's sort of two streams. There's my kind of personal progress that I have to tick certain boxes. I have a little bit of training to finish before I reach a consultancy post here in the UK. Of course, I've got to finish my PhD. But sort of more interestingly, as where do I see psychedelic research going? I think in general, I'm pretty optimistic, although cautiously optimistic. I do have a little bit of reservation that if things are rushed through too quickly, which might happen, I don't know, but that might, it will just take one case of, malpractice to sort of bring everything down that people have worked quite hard on. And I think, I suppose one thing we've not touched on so much is the kind of the fact that psychedelics get people into a very vulnerable and quite suggestible state sometimes. I mean, it depends on the individual, and there have been cases where, I mean, there's one particular case I think about with an MDMA therapist practitioner in I think in Canada or the US who, there was essentially allegations of abuse that were, and that was pretty bad, and it's exactly what you don't want to happen. I think in
worst case, horrible
absolutely,
abuse,
yeah,
malpractice in any medical setting, anesthesia settings, dental settings. I mean, it's just like
yeah. I guess the thing about psychedelics, I think, is they may lend themselves to, because of the suggestibility aspect of it, particularly. That I'm not saying things will go wrong, but I just, have a little bit of anxiety that just takes one weirdo just to ruin everything for everyone.
Yeah,
but
that's pretty valid fear, actually. And you have to have a public and in regulatory body that's robust enough to tolerate that sort of inherent bad actor that might utilize something of this with this power for nefarious purposes or selfish purposes.
Yeah, exactly. But otherwise, I think there is real optimism, and I think that I do envision that it maybe that these drugs are eventually make it into clinical practice in some sense. I think the strongest way of evidence is for depression at the moment. Other things like substance use disorders potentially as well, and maybe trauma-based disorders. But I think we're still quite a few years off that. For FND, I suppose most interestingly, I think that as I kind of mentioned, this is the very first step. This will be the first time as a group in Australia are also doing a trial as well, probably starting at a very similar time to me. This would be the first time that modern era that someone with FND has been dosed with psychedelics. So we're very sort of taking baby steps with it. But I think that if this sort of works out okay, then the obvious next step would be a sort of more clinically trial-focused intervention for this patient population. So thinking more explicitly there about whether or not these drugs can improve clinical outcomes for patients. And I think there's also really interesting avenues about, because we talked before about the fact that this is not an explicit sort of FND therapy that participants will get in my trial. It's sort of supportive psychological therapy, but whether or not an active intervention will be perhaps the more interesting or have more utility in this patient group. So thinking about something a more FND specific intervention, but we're not there yet for thinking about that. There is just whilst we're on this topic, there is a group in Melbourne led by Richard Kanani, who are also doing a really interesting trial in FND and motor functional symptoms, and the plan for them is to actually use the window of plasticity invoked by psychedelics to sort of do physiotherapy interventions around that time. So the idea being that the psychedelics may get the brain into a more plastic state.
So within a psychedelic induced state to add motor retraining.
Yeah, so either to do it during or to give a dose where it's not really possible to do it during, and then do it immediately after the day afterwards or the days afterwards.
Got it, like shortly within that kind of post post-psychedelic window in which there's likely still some plasticity or activity, but not full hallucinatory effect. Okay,
yeah, exactly. So that would be using kind of established, FND specific physiotherapy interventions. So maybe just be that case that the psychedelic augments the therapy, which I think they're really brave for doing that, because it's the first time that psychedelics and physiotherapy are combined, and also in quite novel patient group. So yeah, it'd be really interesting to see how they get on.
Yeah, that's wonderful. I hope the listeners take away something similar. One of my main takeaways from just having this conversation with you, so thank you, is, I think there is this, as you said, like this expectancy or this hype around, like psychedelics is kind of being like the Wild West of, just throwing things at patients and seeing what works, which can sound scary or dangerous or irresponsible. But if anyone listens to the way you speak about using these substances with this population, it is endlessly thoughtful and methodical, and considering step by step a safe way to do this, a safe way to approach the broader question, not jumping those guns, not going to extremes, and really making sure that you're kind of balancing the risk versus reward very nicely, which is we don't want to be overly cautious and miss an opportunity to potentially help patients with the use of psychedelics, right? But you don't want to be so overly optimistic that then you miss or engage in a practice of a novel intervention with something as powerful as potential psychedelics, that in a way that's not helpful, right? But you're taking a very nice approach of thoughtful, considered, methodical, while still hopeful and optimistic around the potential impact, which hopefully is one of the listeners' main takeaways from this. It's not just, a radical thing. It's actually quite, thoughtful and well reasoned and sort of well paced. Just kind of the paced nature that you're describing the approach is, I think, really essential. And so in a way, I think, the FND community is really lucky to have such a thoughtful person come in and attempt to use psychedelics with the population in this way, right? Not just, we'll just throw it at them and see what happens. It's just, no, it's just coming from such a thoughtful, grounded, well-reasoned lens, and a safe, there's just so many different layers of safety that you've added. And even for the longer duration and process of the longer next steps before it would even become clinically accessible or applicable. And I think that there's a lot of utility in that. And the FND community is really lucky to have a researcher who takes that approach, right, for a condition that has its vulnerabilities, right? And for a condition where there's not a lot of treatments, it could be very prone to lots of aspects of intervention that aren't particularly well thought through. And your approach isn't one of them. So that's thank you for that. That's great for the FND community.
Thank you. I'm enormously flattered. Thank you very much for your kind words. I mean, if I could, if the take home is that, I'm a thoughtful researcher and clinician, then, everything I've done has been a success. So thank you very much. It's much appreciated.
Yeah, wonderful. Okay. I think on that note, I will end. However, I would like to say, once your studies are published and you have additional results from the one that you've alluded to that are not yet published, but I'd love to hear about, and then any outcomes from your currently funded trial that hopefully will start recruitment soon. You'll have to let us know how those go. We'll have to have you back. Keep hearing.
Absolutely. Delighted to come back and give you hopefully good news, or maybe not so much good news, but let's see.
Hey, you never know unless you try.
You never know. Exactly.
Yep. Yeah. And then we'll be sure to include at the end of this podcast as well, with the posting links to various websites that you have, especially for your upcoming trial. If people hear this and want to refer patients, especially in the UK. Probably not so much in the US unless someone wants to.
Unfortunately not. Sorry.
Limited. But we'll include those links as well. So thank you so much. It's been such a pleasure. And I'm sure our listeners also agree and enjoy. And we look forward to having you back.
Wonderful. It's been so nice talking to you, Erica. I do appreciate it. Thank you so much. And thank you everyone for listening.
As a reminder, listening to this podcast gets you access to a 50% discount for new FNDS membership. Use code FNDS005.